Hey, this is Dr. Bernie Hansen, and in this video I'm going to demonstrate the proper use of the syringes, needles, and tubing we've provided in your goodie bag when you practice one-hand syringe handling and venipuncture. In that bag you'll find a 3 milliliter syringe with a 22 gauge injection needle, a 6 milliliter syringe, at least one 20 gauge injection needle, and a piece of 1/4 inch latex rubber tubing. All syringes follow the same basic design. The largest component is the syringe barrel, with a flange at the plunger end and a lure adapter at the injection needle end. This adapter can either be a smooth tip, called a slip lure, that holds a needle connection by friction only, or a lure lock that uses a screw connection to firmly hold a needle or medication tubing in place. The plunger moves inside the barrel and has a flange on the end and a soft plastic barrel seal at the tip that provides a leak-proof seal between the atmosphere and the contents aspirated into the barrel. The barrel is calibrated in milliliters, and as you should recall, 1 milliliter is equivalent to 1 cubic centimeter or 1 cc. The sizes we carry in the teaching hospital are 1, 3, 6, 12, 20, 35, and 60 milliliter. The 1 and 60 milliliter sizes cost between $1 and $2 each. The 3 milliliter size is the cheapest and costs around 6 cents. When collecting blood samples or administering medications as a single injection, we usually use 3 milliliter syringes and essentially always use syringes 12 milliliters or smaller. All of these can be held and manipulated with one hand, and in fact, a one-hand technique is essential for successfully collecting blood with minimal risk of unnecessary injury to your patient. So, I want you to begin this course by practicing the proper way to hold and manipulate a syringe using one hand. The technique requires a 3-point hold, positioning your index finger below the barrel of the syringe, your middle finger below the plunger, and pressing down with your thumb on top of the syringe barrel just in front of the finger holds as demonstrated here. In a new syringe, the plunger barrel seal is usually adhered at the lure end of the barrel, and it can require considerable force to loosen. Therefore, before you use the syringe to aspirate blood or medication, you should use both hands to pull the plunger back in a step that is often referred to as breaking the seal. When I do so with the 6 ml syringe, you can hear a little pop as the black plastic seal breaks free from the end of the barrel, and then the plunger can easily be pulled and pushed with one finger. I want you to practice at least 100 reps of aspirating 3 milliliters of air with your syringe by holding it with one hand and using your middle finger to withdraw the plunger and the side of your ring finger to push the plunger and expel it. Keep practicing until you can aspirate a full 3 milliliters and eject it with smooth motion and minimal movement of the lure end of the syringe. If your glove size is smaller than 7, you will find it much easier to aspirate 3 cc's with a 6 ml syringe than the smaller one because the plunger does not have to travel as far in the larger syringe as shown here. Both of these syringes hold 3 milliliters of air, but the plunger on the larger one had to be pulled back only a little more than half the distance as it did in the smaller one. Once you have practiced syringe manipulation and are confident that you can aspirate and eject 3 milliliters of air while holding it steady with one hand, I want you to practice venipuncture with the black latex tubing from your goodie bag. To accomplish this, you will need a cylindrical object like the soda can I'll use here to mimic the antebrachium of a dog. Depending on your glove size, possible alternative objects to use include beer bottles, glass condiment jars, a broomstick handle, a paper towel tube, or the plastic case from a 35 or 60 milliliter syringe. Use Scotch tape or packing tape to secure the latex tube to each end of the cylinder, stretching a little bit between the 2 points. This will be your model of a dog's cephalic vein, and you'll demonstrate your venipuncture proficiency to your instructor using a similar model in the lab session on ultrasound and venipuncture. In upcoming lab sessions, you'll collect blood from the cephalic, lateral saphenous, and external jugular veins. The principles I'll show you here work for both legs, and we'll save the jugular vein for later in the semester. When collecting blood from the cephalic vein in live dogs, your laboratory partner will restrain your dog, usually in a sitting position, but this could also be standing or in sternal recumbency, whatever is most comfortable for your dog. Your partner will lift the front leg by the elbow and compress the cephalic vein just distal to the elbow joint, as shown here. Using this soda can model, I'll demonstrate how to position your hands for venipuncture of the cephalic vein. If you are right-handed, you'll find it easiest to perform venipuncture on veins on the dog's right side. And if you're left-handed, you'll find it easiest to perform venipuncture on the dog's left. I'm right-handed, and here I'll demonstrate the technique for venipuncture of the dog's cephalic vein. When collecting blood from a right cephalic vein, I use my left hand to lift and stabilize the antebrachium and hold my left thumb just lateral to the cephalic vein to stabilize it and prevent it from moving in a lateral direction when performing venipuncture. If I collect blood from the dog's left side, my thumb will stabilize the vein on the medial side. Instead of directing my needle right over the top of the vein, I'm going to approach the vein a little bit from the side opposite of my thumb, as I am exaggerating here. To perform the venipuncture, I rotate the opening of the needle bevel up away from the tubing and approach the tubing at about a 30-degree angle relative to its long axis, penetrate it, then lower the plunger end of the syringe to make it as parallel to the tubing as practical. Then I lift slightly to bring the shaft of the needle up to the superficial wall of the tubing and advance the needle on the midline until it is fully seated. Here I am demonstrating the same maneuver with a 6 ml syringe and a 20 gauge needle. Penetrate, lower the syringe, lift the needle, and advance to the hub. Here is a side view of the same maneuver. I'm holding my thumb immediately next to the tubing vein, and I will approach the imaginary skin and vein with my needle at around a 30-degree angle with the needle bevel oriented up. In the live dog, it's critical to apply at least 1/4 cc of vacuum with the plunger as soon as the bevel is in the skin and before it enters the vein. This will ensure that the instant the needle enters the vein, you'll get a flash of blood into the barrel of the syringe. You can mimic this maneuver by aspirating a bit the moment your needle catches on the tubing, as I did here. Once the needle is fully seated, I can aspirate my sample. Here's an extreme close-up. As soon as the needle enters the tubing, I lower the plunger end of the syringe to make the needle parallel to the long axis of the tubing, lift the shaft of the needle against the superficial wall of the tubing, and advance the needle to the hub. The needle bevel opening is oriented up so that the needle behaves like an upside-down ski tip, preventing the needle from penetrating the wall of the vein. Once the needle is fully seated in a vein, I could lower the needle shaft away from the superficial vessel wall to put it into the center of the vein and aspirate my blood sample from there. Inserting the needle shaft completely into the vein and keeping it parallel to the long axis of the vein minimizes any risk that my needle will accidentally withdraw or penetrate the wall of the vessel because of unexpected movement. Here I'm introducing another technique you'll use on your dogs, using your thumb to apply compression and hemostasis at the venipuncture site before you withdraw the needle. This will prevent blood from immediately spurting out of the skin upon needle withdrawal. When the needle is safely out of the limb, your assistant can continue to apply pressure to the puncture site while you process the blood sample. The site will usually not bleed if the assistant maintains pressure for around 20 to 30 seconds, but if it persists after that, you can apply a light compression wrap with a 2x2 inch gauze sponge and some non-adherent elastic bandaging. In this final maneuver, I am administering an intravenous injection of 2 milliliters of air in my 6 ml syringe. When injecting medication intravenously, I follow the same principles used for venipuncture. As I advance the needle into the skin, I apply vacuum with the plunger the moment the needle bevel is within the dermis, advance the needle into the vein, and observe the flash of blood mixing with the medication, then lower the plunger end, lift the needle shaft, advance to the needle hub, aspirate a second time to confirm that the needle is still in the vein lumen, and inject the medication by pushing the plunger in with the side of my ring finger. You should also do one last aspiration to confirm that the needle has not left the vein before withdrawal. I'll conclude with this tip. Look at what happens if I forget to orient the needle bevel up. When I penetrate the tubing, lift, and advance, the needle immediately penetrates the wall of the tubing. This is the primary reason behind the universal recommendation to hold the needle bevel opening up and away from the leg. Please practice these steps until you're proficient at manipulating the syringe with one hand and performing venipuncture on the tubing model. In the week 4 session on ultrasound and venipuncture, we'll require you to demonstrate your proficiency at these steps before you'll be allowed to practice it on your dog in later sessions. See you there.